questions which were presented by the New York senior students, second year batch. Found them quite interesting, and some of them are very latest and likely to come in the future exams. So I thought of discussing that with the students. We have discussed part of it last week. So we are going to discuss another 5 topics or 5 questions that were asked. The methodology is students will prepare the answer and they will present it here. Any corrections or any additions and omissions or how to present it better will be the advice given. So that is the pattern we have been following. So today Dr. Rafeefa will present the first topic or first question. You can go ahead, Rafeefa.
My first question is lemon score. Lemon score is a score which is used for difficult airway assessment. It represents 5 simple, reproducible, and rapid assessment methods on uncooperative and cooperative patients. L is for look externally, which consists of facial trauma, large incisor, beard or mustache, and large tongue. Each gives 1 score. Each gets 1 score. And second one is E. E is for evaluate. That is 3:3:2. First one is first 3 is for mouth opening, less than 3 finger breaths. Again, difficult airway, score 1 will come. Then ioid mental distance less than 3 finger breath. That is also 1 score. Then thyroid to floor of the mouth distance less than 2 finger breaths. That is the 3:3:2. Then third one is the M, that is the Mallampati score. Mallampati score 3 or 4, each will get 1 score. Then fourth one is the O is the obstruction, where presence of any airway obstruction, each that will get 1 score. Then the last one is the N, that is the neck mobility. Neck mobility is if it is decreased, it will get a 1 score. So in short, each of the lemon elements is worth of 1 point. And if the patient is unable to cooperate, the Mallampati score is not scored. So total maximum airway assessment score will be 10 with Mallampati and 9 without Mallampati. The higher the score, more likely the intubation will be difficult. That's it, sir. Lemon score.
Yeah. What is the earlier name for that? Is it called lemon score from the beginning, or was it called by some other name?
Lemon law, sir, it was called.
It was called lemon law. Very
Lemon
good.
law.
What was
It was lemon law.
Who introduced that?
Walls in 2000 introduced lemon.
Walt or by some other person? I don't think it was Walt.
In 2015, it was by Hagiwara who invented this lemon score. 2015.
They were all people who made some alterations in that. The original person who described the lemon law, the so-called lemon law, was Binoni. B-I-N-N-O-N-I. Binoni. Binoni's lemon law was the original person who described all these things. It is one of the very easy clinical methods of assessing the difficult airway. Okay, very good. Okay. So this much of answer is enough, because you have to expand the acronym and then give how you grade them. Then you say based on the marks or the grades that you get, how you classify the difficult airway. Okay, that is all. So no need to write paragraphs and paragraphs. Whatever exact description of what you have given is more than enough for a short note question in this. Excellent. Good. Okay. What is the next one?
Next one is physiological difficult airway, sir.
Okay.
Physiological difficult airway. Physiological difficult airway refers to airway management in a critically ill patient with severely or severely dearranged physiology, which poses increased risk of cardiopulmonary collapse and even arrest during or immediately after airway management. So this physiological dearrangements is divided into 5 entities. First one, second one is hypotension. Third one is right ventricular failure. And fourth one is severe metabolic acidosis. And the last one is neurologically injured patient. One is hypoxemia. We all know hypoxemia can be due to type 1 respiratory failure or type 2 respiratory failure. Type 1 respiratory failure can be due to pneumonia, pulmonary embolism, ARDS, etc. And type 2 can be due to COPD, reduced respiratory drive, severe bronchial asthma and all. So pathophysiology in hypoxemia may be due to, there will be ventilation perfusion mismatch. There can be shunt physiology. There can be diffusion limitation or hypoventilation. Low inspired FiO2 can be there. So what happens in these patients, there will be rapid desaturation, arrhythmia or anoxic brain injury, and going to cardiopulmonary arrest while attempting for intubation. So to avoid, we have to, before trying to intubate these patients, we have to first pre-oxygenate in these conditions. Also pre-oxygenate to maximize the hemoglobin saturation. Second one is to maximize the partial pressure of arterial oxygen. So it increases the safe apnea time. So here we can give 100% oxygen over 3 to 4 minutes, or normal tidal volume, or 8 vital capacity breaths. The adequate pre-oxygenation can be, we'll get to know by ETO2 more than 90%. So how to give a pre-oxygenation? Usually it is done in upright position, ramp position, or ramp position to improve the view. Then increase oxygen. Either you can use with flush through the non-rebreathing mask. You can use or non-invasive like NIV you can keep, or you can use a bag and mask ventilation with the. Then another method is a high flow nasal oxygen. With 40 to 70 liter per minute, or you can even use a iGel or supraglottic airway device to give pre-oxygenation. If there is a very refractory hypoxemia, awake intubation is considered with preserving the spontaneous ventilation. Then there is something called delayed sequence intubation, where you can give ketamine 10 to 20 mg, which can administer to induce a dissociated state to allow pre-oxygenation with a non-rebreathing mask or NIV mask. Then slowly, prior to administration of the muscle relaxants, instead of ketamine, you can even go for dexmedetomidine also. Another method is like here it's like oxygen removal from the alveoli by circulating the blood brings alveolar pressure to subatmospheric pressure, getting a negative pressure gradient, drawing oxygen from the upper airway into the lungs. So during intubation also you can continue giving the patient oxygen by HFNC, whiteboard nasal prongs, or oxygen flex, or Thrive. Thrive is transnasal humidifier rapid insufflation of insufflation ventilatory exchange. Then second entity is hypotension. Hypotension is where it's a definition, there is any in the 6 post intubation, systolic BP less than 90, mean arterial pressure less than 60, and any use of vasopressor. So risk factors for this hypotension is initial BP before intubation is low, less than 6 mAp, less than 60, or a shock index. Pre-intubation shock index elevation more than 0.8. Usual shock index is heart rate divided by systolic blood pressure. Normal is 0.5 to 0.7. If it is more than 0.8, it is an increased risk factor. Then intubation for acute respiratory failure, advanced age, and chronic renal failure. In this one, mainly pathophysiology is mainly volume depletion, or it can be due to capillary leak, decreased venous return, loss of systemic vascular. Here treatment is like before going for intubation, we have to make the patient hemodynamically. If first we have to see whether the patient is fluid responsive. If patient is fluid responsive, you can increase the cardiac output 15%. 15% of cardiac output can be increased by giving fluid challenge. If the patient is not fluid responsive, you can start early administration of vasopressor. Like noradrenaline is most preferred one. If post intubation there is a BP file, you can give 50 to 100 mics of phenylephrine policies. And for intubation, IV induction agent, avoid propofol. You can always go for etomidate or ketamine. Then third entity is right ventricular dysfunction. Right ventricular dysfunction pathophysiology. It's like it can be due to increased afterload, where in case of pulmonary hypertension, pulmonary embolism and all, or it can be due to reduced contractility in case of RV ischemia, RV myocardial infarction and all, or abnormal preload where you will have hypovolemia, hypervolemia, or this one pericardial tamponade in condition. Then altered interdependence in case of again pericardial tamponade and septal shift, or altered rhythm like tachyarrhythmia, bradyarrhythmia, everything. This all will lead this patient like increase afterload will cause that myocardial oxygen demand supply mismatch and can go into ischemia of right ventricle, which will lead to right heart failure. Or this ventricular interdependence and shift of the interventricular septum will also cause the reduce the cardiac output, and it will simultaneously call left heart failure also. So here you have to diagnose it by you have to inform the if you are suspecting RV dysfunction, you have to always inform a cardiologist, and you should ask for an echo. You should see whether the patient is fluid responsive. Then first is before intubation, you should stabilize the patient. Like first pre-oxygenation should be adequate. Pre-oxygenation should be given. If at all induction, you should use etomidate. Fentanyl. Adrenaline infusion should be started prior to induction, prior to intubation, to achieve a goal, to achieve stable pressure. Dobutamine, levosimendan, or milrinone like inotropes can be started. Then, if after mechanical ventilation, you should keep the patient with low mean airway pressure with high PEEP. Avoid hypoxemia, atelectasis, and hypercapnia in these patients. Then, the fourth one is severe. In these patients, it can be due to increased neuromuscular drive, any poisoning, salicylic poisoning, lactic acidosis, many reasons causes are there. Here, first and foremost thing, should avoid intubation. Before stabilization, we should always avoid intubation. Better to use NIV, non-invasive ventilation, to reduce the work breathing and reduce the EtCO2. If at all you need if at all intubation is mandatory, you can go for awake intubation with the spontaneous breathing. Rapid sequence intubation should be always avoided. Then consider spontaneous breathing after intubation also, because these patients will have high minute ventilation to compensate the severe metabolic acidosis. So here PSV or PCV, pressure support ventilation, will be more preferred. And here also we can go for high flow nasal cannula or ventilation. The last one is neurologically injured patients, where in these patients you have to maintain eucapnia and normoxemia, maintain cerebral perfusion pressure, control the intracranial pressure. A patient should be positioned 30-degree upright, and hemodynamically stable induction agent should be used. Intubation, we should use any like beta blockers or lignocaine to attenuate the intubation response. Esmolol, fentanyl, lignocaine, all can be used. And after intubation, optimal limit PEEP to promote the cerebral vascular drainage. That's it, sir.
Excellent, very good. Now you described about 5 clinical scenarios or conditions where you may land up with a physiologically difficult airway. Okay. All these days we were talking only about anatomical difficulties. When we talk about difficult airway, automatically people used to think it is only the anatomical difficulty which is going to cause a problem in securing the airway. Whereas now, in which situation you will see this type of patients? Whatever you have described now, these type of patients who require intubation, who are considered as physiologically difficult airway patients, under what circumstances you require to intubate such patients? Where do you see normally in a hospital setup, where do you see this type of patients?
ICU, sir, critical care.
ICU or trauma?
Trauma.
Okay? Emergency. These are the two situations where you will come across this type of patient. And I don't know how many of you have experienced. Patient comes in a very moribund condition, and somebody asks you to intubate, and you put in a laryngoscope. You are able to visualize the glottis. You put in a tube, and the next minute the patient, your assistants are saying there is no pulse, patient has arrested. So immediately after intubation,
those are the patients who are completely hemodynamically unstable, not because of that. This is what is called the physiologically difficult airway. So it's basically the change that happens in the physiology of the patient, which, when we do an airway interference, will affect the outcome of the intubation. That's what it actually means. All right. Okay. You did a good one. You did a good presentation. No problem. Any other doubt you have on this? Do you have any doubts on this? On what you read? Do you have any doubts on what you read?
Yes, ma'am.
You're okay?
Okay, ma'am.
Okay, then we can continue with the next topic.
Yes, ma'am. Thank you, Dr. Rafeefa. Who is going to present next topic?
Sir, I am going to present, sir.
Can you switch on the video for a moment?
Sir, I am not
Or,
able.
the presenter is the, pardon?
No, sir, I am not able to understand where